Medical surgical cardiovascular systems. Today we'll be discussing heart failure, both left and right ventricular failure. So the etiology of right ventricular failure is very simple. The right ventricle isn't pumping effectively, and the right side of the heart can't pump blood to the lungs efficiently. In left ventricular failure, the left ventricle is not pumping effectively, and the left ventricle cannot be pumping blood throughout the systemic circulation. Now, it's important for students to understand the basic anatomy and physiology of the heart. They should understand that the right side of the heart carries or brings in oxygen poor or deoxygenated blood from the superior and the inferior vena cava, and it's supposed to send blood to the lungs via the pulmonary artery. The left side of the heart is supposed to receive oxygenated blood or oxygen-rich blood from the lungs, and it's supposed to send blood to the systemic circulation via the aorta. In heart failure, it should be understood that it can be caused by coronary artery disease, myocardial infarctions, and chronic hypertension. The most common cause of right ventricular failure is left ventricular failure. Some other contributing factors of heart failure include, but are not limited to, chronic hypertension, chronic lung disorders such as COPD, and this can cause something called cor pulmonale, which is essentially right ventricular failure caused by chronic pulmonary issues. This happens when in a chronic respiratory issue like COPD, you have the pressure inside the pulmonary arteries that are increasing, and this shoots the pressure back to the right ventricle, and the right ventricle tries to compensate by beating faster, and throughout the years, this causes fatigue and eventually right ventricular failure. Clinical manifestations, well, we'll start off with right ventricular failure. In right-sided heart failure, this causes the blood to back up to the superior and the inferior vena cava, which congests the body's systemic circulation. This includes fluid retention, causing jugular vein distension, and increased central venous pressure, or CVP. The patient will also manifest oliguria throughout the day or decreased urine output, and then diureses or an increase in urine output throughout the evening. Now, this happens because throughout the day, the patient is more physically active, the fluid stays in the tissues, which cause edema, and this decreases the fluid that's going inside the systemic circulation. This decreases the perfusion of the kidneys, which thus causing a drop in urine output or oliguria. At the evening hours, when the patient becomes less physically active, they usually elevate their extremities, and this increases venous return, which causes the fluid to shift back towards the systemic circulation. Thus, the kidneys become more perfused, and that causes diuresis. Patients should understand that they will also develop in right ventricular failure, they'll develop hepatomegaly, or the liver getting bigger, splenomegaly, the spleen getting enlarged as well. And this happens because the inferior vena cava is backing up or congesting the liver. The patient will also develop GI discomfort like nausea, vomiting. The patient will also develop fluid retention and weight increase. And remember that 1 kilogram of weight equals 1 liter of fluids. The clients eventually may develop portal hypertension and esophageal varices, as seen in a lot of liver issues. The patient may also develop ascites because the liver becomes congested. The portal hypertension also increases, and that causes the fluids to escape from the portal veins into the tissues, thus causing ascites. Now, when it comes to left ventricular failure, most of the clinical manifestations deal with pulmonary issues. The left ventricle receives blood from the lungs, like mentioned previously. So when the left ventricle failure occurs, it begins to back up towards the lungs. This causes pulmonary congestion. Pulmonary congestion, such as crackles upon auscultation, is manifested. The patient will also be coughing up blood or having hemoptysis. The patient will have an inability to breathe well when they lay flat, or they'll have or experience orthopnea. They'll also experience something called paroxysmal nocturnal dyspnea. This is a feeling of drowning when the patient's laying flat, and it usually happens while they're asleep due to the sudden fluid backing up to the left ventricle of the lungs. The patient may also develop tachycardia as a compensation. Clients will have cold extremities from decreased cardiac output and decreased perfusion to the extremities as well. And of course, weight gain due to the fluid retention. So it's imperative that we weigh the patient daily. Some diagnostics for heart failure include BMP, or brain type natriuretic peptide. This is a hormone that's released by the ventricles when they're being overly exerted. Now, this isn't supposed to happen because the ventricles are supposed to be tough. You know, they're given the responsibility of pumping the entire body's circulation or the circulatory volume throughout the system. So when the BMP goes above 100, that's an indication of heart failure. The patient will also have their stroke volume and cardiac output assessed, which will decrease. We may also provide the patient with a stress test. That's when we put the patient on a treadmill and we find out how well their heart can tolerate the increased metabolic demands or the increased cardiac demands. We can also assess something called the ejection fraction, and this is a percentage of the volume of blood that the ventricles are pumping out every beat. The average is about 70%. But when someone has heart failure, it drops to less than 40. So anything that's 40% or less is an indication of heart failure. We can also utilize electrocardiograms, which represents the electrical representation of the heart as it beats, and that in conjunction with a stress test can also be carried out. We will also be conducting chest x-rays, CBCs, cardiac MRIs, coronary angiography, nuclear medicine as well. Sometimes we inject radioactive isotopes or non-radioactive isotopes, to the systemic circulation, and we visualize how well that those isotopes are being absorbed by the ventricles, and that lets us know if the heart is doing what it's supposed to be doing. We could also place the patient on a Holter monitor, which continuously assesses the electrical representation of the heart. And we can also do right heart cardiac catheterization, which assesses pulmonary pressure, and something called the Swan-Ganz catheterization. The medical management of heart failure is pretty basic. Initially, we want to give medications such as furosemide or Lasix. We can give hydrochlorothiazide, and those medications are supposed to get rid of the excessive fluid inside the body. We can also give digoxin, which increases the cardiac contractility, and that improves cardiac output. We can also give certain antihypertensives like beta blockers or metoprolol, ACE inhibitors or lisinopril, or angiotensin receptor blockers or losartan. Those medications, what they do is that they decrease blood pressure, they vasodilate the peripheral vessels, and they decrease the workload of the heart. The important component of this is to decrease the peripheral resistance. And it's important for students to understand that. Peripheral resistance is the how tight or how pressurized the blood vessels of the arms and legs are, and when the heart is pumping. So if the heart's failing and we can ease up how much pressure is found inside those extremities, well, then the heart will have a less hard of a time pumping blood outside of its ventricles. We can also give patients aldosterone receptor blockers like spironolactone. And then we also have hydralazine and even nitrates, which are usually effective in the medical treatment of heart failure. Some dietary medical management includes giving the patient or providing the patient with a low sodium diet. Remember to adjust potassium accordingly depending on the type of diuretic that's being utilized. And what I mean by that is if the patient's using potassium depleting diuretics like furosemide or hydrochlorothiazide, then we want to increase the potassium in the diet potentially to prevent hypokalemia. But if the patient's receiving medications like spironolactone or aldactone, that's a potassium-sparing diuretic, and that may cause potassiums to go up in the bloodstream. So we'll give them a decreased potassium diet. Some nursing measures include elevating the lower extremities to promote venous return when people have things like right ventricular failure. Weigh the patient daily to monitor the fluid retention, and also monitor the therapeutic effects of medication like Lasix. You want to assess potassium levels. Remember that potassium is 3.5 to 5.0. Anything below 3.5 is called hypokalemia. Anything above 3.5 is considered hyperkalemia. And since the patient's taking digoxin, keep in mind that hypokalemia may cause digoxin toxicity. So it's important for us to monitor those potassium levels. Keep the head of the bed elevated to alleviate pulmonary congestion and to promote respiratory effort in people that have left ventricular failure, and provide rest periods throughout physical activities. Assist with pursed lip breathing and expectoration to eliminate any respiratory complications as well.